Now we're going to look at somatic symptom disorders. And again, this is a repeat from part 1 in terms of its historical link with sort of disorders with forms of neuroses, in particular around this link with anxiety. And somatic symptom disorders involves physical. Now, soma means body. And so these are about physical complaints. And they're related to underlying psychological conflicts and issues. Okay? Overly preoccupied. Now, people with somatic related disorders will be overly preoccupied with their health or their body appearance. No identifiable medical condition causing any of the physical complaints. And so examples will be conversion disorder, illness anxiety disorder. This was also used to be known as hypochondrias, and somatic symptom disorder. So these ones, again, not particularly common, although there will be variations. And remember, a lot of the DSM-5 is on a dimension, so it's like a scale from extreme none to extreme a lot. And most of this will fit somewhere somewhat in the middle here. And so with somatic symptom disorders, they're on the extreme. Okay? So let's get on with this one. We're going to look at types, we're going to look at theories, and we're going to look at treatments.
Conversion disorder, or functional neurotic symptom disorder. This type of somatic symptom disorder characterized by loss or impairment of physical function in the absence of any organic cause that might, account for the changes. Now, physical malfunctioning without any physical or organic pathology. Malfunctioning often involves sensory motor areas retaining most normal functions without awareness of this ability. Now, if you check out on table 5.3 on page 201, you'll get a little bit of the DSM-5's perspective about what are the criteria. Now, in that particular disorder, it's related to, but different from, illness anxiety disorder. Now, illness anxiety disorder is a preoccupation with the fear of having or the belief that one has a serious medical illness. But there's no medical basis for the complaints that can be found, and the fears of illness persist even when they go see and get medical reassurance. So is this fake or real? Well, people with illness anxiety disorder do not consciously fake their symptoms, but fear their symptoms are due to a real illness. Feeling resentful towards their own doctor, they often go doctor shopping from one doctor to the next. Now, this is a disorder that used to be known as hypochondrias. Now, the physical complaints, without a clear cause, there can be severe anxiety focused on the possibility of having a serious disease, some strong disease conviction, and the medical reassurance doesn't help. Now, you'll find this information on table 5.4. Somatic disorders, somatic symptom disorders, they're involving reoccurring and multiple complaints that cannot be explained by any clear physical causes. You're seeing a very common theme here. There's no physical reason for the existence of their discomfort, their pain, or in this case, the sort of preoccupation with how they appear. Now, there's an extended history of physical complaints before the age of 30. There's substantial impairment in social and occupational functioning. Now, this is an emphasis that's really important throughout all disorders, is that these disorders affect and interfere with regular social involvement and regular occupational functioning. Now, body dysmorphic is really just focused on seeing some element of themselves that they don't think is right. Somehow it's wrong. Maybe their ears are too big, their nose is too big, their eyes aren't of equal size. And it's a preoccupation to a very high degree. They're concerned over the symptoms themselves, not what they might mean. The symptoms become the person's identity. Now, pain disorder is along the same line. And again, you will find more information about this in your textbook. Now, theoretically, looking at, well, why does this happen? What is the explanation? Can we explain a cause? Well, psychodynamics, they view that what holds the conversion disorders represents the conversion into physical symptoms of a leftover emotion or energy that is cut off from the unacceptable or threatening impulses that the ego has prevented from reaching awareness. The symptom is functional, allowing the person to achieve both primary and secondary gains. Primary gains in psychodynamic theory is the relief from anxiety obtained through the development of neurotic symptoms, whereas the secondary gains are the side benefits associated with neuroses or other disorders, such as the expression of sympathy and the increased attention from other people and release the ordinary responsibilities. Now you'll see more explanation of primary gain and secondary gain in page 204, 205. Now, they're not the only perspective on these somatic perspectives. We have learning. Now learning, it focuses on the reinforcements that are associated with conversion disorders, such as reinforcing effect of adopting the sick role. Now the sick role just means that if you're going to say you're sick, you need to adopt the sick role. So for example, someone who's faking sickness and says, I can't make it into work today, I'm overwhelmed with sickness, I'm in bed, but then goes out and socializes with their friend, they haven't accepted and taken on the sick role. So if I'm someone with a somatic disorder, not only do I not make it into work, I am feeling that sickness and will feel I'm take on that sick role. I will be in bed. I will do all the things that someone who is legitimately sick will be doing. The difference is they're not malingering. They believe those symptoms are they're being experienced. A learning theory view likens illness anxiety disorder to obsessive compulsive disorder, where cognitive factors in illness anxiety disorder include self-handicapping strategies and cognitive disorders. And that's really where the cognitive approach steps in, is they look at the cognitive distortions and look at altering those distortions in order to get a more realistic view of how one's experience is. When we look at treatment, we're going to start with psychoanalysis, where they seek to uncover and bring to the level of awareness the unconscious conflicts. Now, if you remember from we see the iceberg, the unconscious is all of that which is beneath the surface. And the conflicts that exist there are, well, as Freud's perspective would be, from back in childhood, where we've either used our defense mechanisms to sort of protect our ego. And so a lot of these unconscious conflicts are originating in childhood that are believed to be at the root of the problem. That once the conflict is uncovered and worked through, the hysteria symptom should disappear because it's no longer needed as a partial solution for the underlying conflict. Now, a behavioral approach will use what we've seen in previous disorders. Its focus is on removing the source of reinforcement that may be maintaining the abnormal behavior pattern. So they'll use what is known as the cognitive behavior therapy, where the therapist will work more directly to help the person with somatic symptom disorder to learn to handle stress or anxiety situations more effectively. Now, biologically, there is a role to play, limited in terms of its success, but antidepressants, especially the SSRIs, like Prozac and Paxil, they have shown some limited success. However, some success. And what you'll find in most treatments, especially in this, but not exclusively, is a shared relationship between, cognitive and behavior, biological and psychoanalysis. Is that it's very rare in some of these treatments now that they'll work isolation of one another. They'll often work in collaboration with one another to resolve some of the issues that get brought forward. And dissociative and somatic symptom disorders are good examples of that. All right, there we go. That is the chapter on dissociative and somatic symptom disorder. This is the end of week 7. You'll be starting your break shortly, and then we'll get into week 8, And in week 8, we're going to look at substance related and abuse disorders. And that will get us onto a good start for the second half of the semester. So good luck, everybody, and enjoy your break. Bye now.